Test, 1, 2. All right. Test, 1, 2. Okay, that's up.
Yes. I know it's working. Uh-oh.
Hello,
Hello,
are you presenting next?
I am not.
Okay.
I'm passing out time sheets for the speaker to know when it's almost time to end. You're doing a good job.
Thank you, thank you.
I would be stressed if I were you.
I've been doing this too long.
Oh, yeah.
Today was my remote day.
Oh,
Yeah, and a couple guys else.
oh. You should have been the other guys.
It happened.
Is it only you?
It's me, I got two of them, one other guy, we
that's-
got, this other guy, yeah.
Okay.
We need a few more staff, you know, how it is. You know, it's just not.
I know. I'm at TVMF and same deal.
Right.
And I'm always the one that's like, oh my God, you gotta come help.
Oh, yeah.
Yeah.
You know,
Yeah.
sometimes we can't.
You can't get there.
We can't get.
I know. We usually figure it out.
I'm gonna do this though before. Hey, Mary. Can. I'm gonna leave it like this because her name was misspelled. But she said that there was a change. Make a change. She's agree when she's putting it in. I had to change because her name is misspelled.
Okay.
So I just came in here before that, but then also, I pulled it out of, into that because, Lauren wants to add something to it.
Okay.
She's gonna call me when they're back here.
Okay, so you updated that and just, we're gonna email all this out afterwards, so we just need to find a way to get the saved copy somehow back, and my drives are not letting now me sign into anything. I don't know, like ODU is like just bouncing me out whenever I try to sign in now. I'm just gonna upload the dad's presentation really quick, because they're in this room second. Okay. And I'm in here with them for the next presentation, so I can help them with anything
Okay.
in terms of the actual, like if they need to make changes. Luckily, it's let me along. in the
It's
email.
about that. She said, I'm driving. It's about that. She's coming to my event.
Yes.
For me.
Automatic voice message system, 757.
I'm with Miss Parker.
You shake.
So it's closing. These copies, I've got it saved on the desktop.
You can close that one out, not with the place.
Yeah. So this one is the second one, this one's the next one. They need have a few changes they want to make, so they want us me to leave it like this for them to come in and be able to easily make changes. Ready. I'll just do this and they can figure out how to escape. Yeah.
And it was shared.
Yeah, and I'll be in this room with them, so as long as, like, if they need help, I can help get them. All they have to do is hit escape, so.
Yeah, it's.
All right, and so Mary's link is allowing sharing, right? But they
So
use
210, this room. This room.
210, okay, 210.
So they share now, see.
I'm gonna try real quick to see if it'll let you do it. Okay, perfect. Yep.
This. Yep, whoever. Yeah, it's working now. I'm gonna stop sharing.
Or actually, if you want just to share in case anybody gets there early, and then they'll just see the conference slide. And we could check on some things, I think. Are there any other breakout, presentations? So I got Dr. Williams, servers is set up, so,
I don't think we have one for our panel.
this one, that one has one now. This one doesn't, but I don't think they're
Yeah,
planning on
that's,
it. They
that's
have,
on that one.
this one has one now. I haven't gotten this one yet. I don't have one for this one, but again, I don't think we're gonna use one for 7 anyways, and I do have one for 8.
Yeah,
so-
that's me too. That's
So it's really just maybe this one if Dr. Wardlaw has a,
Been forwarded to voice.
no one's picking up. I'm trying to get, in contact with Rochelle because Dr. Locke is on her way.
I think we're good except for possibly this one.
Okay.
And so it's just, I don't know her, but so if you see her, you can text me so I can connect, so I can get her presentation uploaded. I'm just having trouble right now, like it won't let me. Because I must not get logged out here on. That I'm logged in somewhere and it won't let me open another thing, which is a pain, you know what I mean? Like,
Yeah.
so, anyway, hopefully that'll.
Okay.
So let me make sure to log out really quickly. Did I log out? I can't remember.
Yeah, I was just checking, make sure sound going out. So, go ahead.
Just want to make sure that way. Should I do us right now?
That's what I have to do now. Well, now that we.
Hello, can anyone hear me? Rebecca? Mary? Somebody, anybody?
Yeah, I can hear you.
Hey, do you see the screen we're sharing? Is it the Standing to Protect Black Maternity?
Yes, yes, it is.
It's not the presenter view, correct?
Correct. Yeah, no, I don't see the speaker notes or anything.
Perfect. Thank you, ma'am.
Absolutely.
It's unmuted, so you
Oh,
full steam ahead.
all right, thanks.
Yep.
Thank you.
You're welcome.
Yeah.
Hello, people online. Can you guys see our screen? I hope. Are you seeing our slides?
We did confirm earlier.
Okay, good. Want to make sure that we can see everybody. We're gonna go ahead and get started. I'm not sure if you guys can see me, hear me, but we're gonna go ahead and jump in. So my name is Amy Paulson. I am the Director for the Consortium for Infant and Child Health, which is the lead group for the Black Maternal Health Equity Action Alliance. And I am really pleased to introduce two great speakers. I've actually heard one of you guys speak before, and it was a great talk, so I'm excited. So Dr. Kenisha Smith-Barber, and Lauren Kozlowski. Okay, in terms of just their background, Lauren Kozlowski is at the Virginia Department of Health, and she works closely with a variety of different teams on things like legislation, programs, policies that are impacting pregnant and breastfeeding individuals and families. And prior to that, she worked at the Center for Maternal Abuse, Substance Abuse and Child Development at Emory in Atlanta. And so while she was there, she focused on maternal substance use prevention and counseling, both in the public and private providers on a variety of different perinatal exposures. And she's currently serving as the treasurer for the Organization of Teratology Information Specialists, and received her bachelor's from the in Women's Studies from the University of Georgia and her MSW at MPH from Boston University. And Dr. Kenisha Smith-Barber is the Community Health Improvement Epidemiology Manager and the primary investigator for the Pregnancy Risk Assessment Monitoring System, or PRAMS, here in Virginia with the Department of Health. And she leads a team of coordinators and epidemiologists who conduct and analyze population-based data here in Virginia, and also works with community and maternal child health partners and researchers to study maternal and infant health outcomes, non-communicable diseases, and areas of improvement in community health. Her work really aims to reduce disparities, and to reduce disparities and improve maternal and child health outcomes using evidence-based data here in Virginia. She holds an MPH and a PhD from the University of North Carolina at Charlotte with a concentration in maternal child health and epidemiology. In addition, she holds the role of adjunct faculty in VCU School of Social Work, where she faces one of her biggest professional challenges, which is making evidence-based statistics digestible and interesting for undergraduate students. So we are super excited for you guys to be talking to us today about exploring implicit bias in care settings and the respectful care model. So I'll let you guys take the reign. Just as a kind of reminder, if anybody asks questions, to speak loudly. The microphones are in the ceiling here. So we just want to make sure that everybody online is able to hear us when we ask questions. And we might ask you to end up just repeating the questions from the people who are asking questions, just in case they can't hear you. Let you go, and you've got a little.
Thank you so much, Amy, for that introduction. So again, Dr. Kenisha Smith-Barber. My role is Community Health Improvement Epidemiology Program Manager. It's a very long title. And my main, what we do is help our local health district epidemiologists with their community health assessment and improvement work. And my other hat that I wear is leading our population health surveys team. So including PRAMS, the Pregnancy Risk Assessment Monitoring System, BIRFIS, which is a survey for adults over 18, and then our youth survey that goes into the schools to get data from middle and high school students. So I'm putting on my PRAMS PI hat for this presentation, and I will get us started. So we're looking at exploring implicit bias in care settings and the respectful maternal care model. So I want to start us off by providing a few definitions of some of the topics that we'll be discussing today. So health disparities are influenced by various factors like socioeconomic status, educational attainment, discrimination, behavior, quality of care, et cetera. And maternal and infant health disparities are diverse, and they can exist among different groups, including insured, uninsured populations, urban and rural communities, private, public insured individuals, and the list goes on. So health disparities are the metrics that we use to measure progress towards achieving health equity, which is a little different from health inequities, which are systematic disparities in health or in the major social determinants of health. So between groups with different levels of underlying social advantages or disadvantages. So understanding these factors contributing to health disparities is largely based on socioeconomic, geographical, racial, and ethnic differences in health outcomes. And then finally, we've seen this graphic from earlier today, but social determinants of health are interrelationships among personal, social, economic, and environmental factors that influence health, and maternal and infant health disparities could be more pronounced in certain racial and ethnic communities due to a wide range of social determinants of health, which are linked to the inequities that racial and ethnic communities experience in the larger social context. So before we get into the implicit bias, we thought it might be helpful to kind of lay out the scene and describe the data for racial and ethnic disparities, potentially due to implicit bias in and out of the healthcare system. So we hope that the data can kind of set the scene for the reason why this discussion on bias is important in the first place. So earlier today, we heard from Dr. Porch on some national data. So I'm presenting Virginia specific data. And most of this, to start off, is coming straight from our birth certificate files at the Virginia Department of Health. So preterm birth is first up. It's the birth of an infant at less than 37 weeks gestation. And when we're looking at preterm birth in Virginia, you can see that while the rates have remained relatively stable over the past 10 years, the percent of preterm births among non-Hispanic Blacks, which is this red line, remains significantly higher than all of their white and Hispanic counterparts, as well as the state rate, which is the light blue line you see. Also, the leading cause of infant mortality is low birth weight. So we're looking at low birth weight here, or birth weight of less than 5 pounds, 8 ounces. So our data show that non-Hispanic Black mothers experience a higher percentage of low birth weight births compared to their peers. And unfortunately, while the white rate appears to be either remaining stable or trending down, the non-Hispanic Black, Hispanic, and state rate appears to be trending up. And then when we're looking at infant deaths in Virginia, we see that non-Hispanic Black mothers also experience higher rates of infant deaths than their peers. We are the bluish line at the top. And in addition, the rate of infant deaths among all mothers has been trending up over the past 10 years. So the question that everybody wants to know is why? Why is this happening? I want to start off by talking about our data source. So up until now, we've used birth certificate data, but these next few points are coming from CRAMS. So I want to give a little background on CRAMS. Anybody in the room familiar with this system? Okay, great, a few. Awesome. So this is a very old survey started in 1987 by CDC, and it's a population-based surveillance system. Moms are randomly selected and they can self-report their maternal behaviors before, during, and after pregnancy. It supplements our birth certificate information because we pull the sample straight from our birth files. And we are able to get state and near national estimates just because not every state participates in CRAMS. So our participants are randomly selected from the birth certificate about 2 to 6 months after the mom has given birth. In Virginia, we sample about 2 to 250 moms each month, and we end up with a sample of about 2,000. And then the data collection is mostly by mailed paper survey, but they also get a QR code when they get the survey, and they can respond by the web. Or if they don't respond, they get a telephone follow-up survey. So we have multiple attempts to try to contact moms and get this really vital information. And I'd like to put in a shameless plug. If you know somebody that has received CRAMS, or your clients or patients get CRAMS, please ask them to take it. It's such an important data source, and it's where we get a lot of good data. So with that being said, we've discussed our data sources. We can get back to discussing these reasons why maternal and child health disparities exist. So our first question I would like to pose is, could it be that genetics are the reason why Black mothers are having worse birth outcomes compared to white mothers? So if we look at this data, the research has shown that Black immigrant women, mostly from African, Caribbean countries, who arrive in the US as adults have better birth outcomes than native-born African-American women. And this proves true in Virginia. So this is Virginia data, we can see 0.6 for foreign-born Black infant deaths and 8.6 for US-born. In fact, the birth weight distribution of foreign-born Black infants is more closely aligning with US-born white infants. So the triangle that's kind of close together is US-born and white infants and foreign-born Black, whereas US-born Black infants are the one that the little arrow is pointing to. So not in alignment with mothers born outside of the US. So genetics is probably not the reason for these disparities that we discussed. So what about risky health behaviors like smoking? So according to our PRAMS data, about 3.6% of white mothers report smoking at or during the last 3 months of their pregnancy, compared to about 2.7% of Black moms. However, the infant mortality rate among African-American non-smokers is still higher than the rate among white mothers who do smoke. So 20.1 for African-American non-smokers, 6.0 for white American moms who do smoke. So behavior like smoking might not be contributing to health disparities, but what about prenatal care? So according to our Virginia PRAMS data, there's not a big difference between the percent of Black and white mothers who receive prenatal care during their first trimester of pregnancy. You can see here almost 93% versus 90%, not a huge difference. But still, African-American mothers in Virginia experience more than double the rate of infant deaths compared to white mothers, regardless of having received prenatal care in that first trimester. So, we don't think it's prenatal care. Maybe it is socioeconomic status that contributes to these disparities. Let's take a second to look at these Virginia-specific examples. So the black bar is for Black infants or Black mothers, and the white is for white mothers. So infant mortality, we see the bar is higher for Black mothers. Black mothers actually get more education here in Virginia, but have lower incomes. And then according to our PRAMS data, again, African-American women with higher incomes still have poorer birth outcomes. So like low birth weight is what we're looking at here. So this disparity exists when compared to white American women with higher or lower household incomes. So the first two bars are for less than 27,000, and the second two bars are for more than 60,000 household income. Okay, and then if we look at education, we see that African-American mothers who get more than 12 years of school still have higher rates of low birth weight compared to white American mothers who get less than 12 years of school. So that being said, let's talk about what PRAMS data tells us about the discrimination that moms face. Our survey asked these two questions. The first, during your life until now, how often have you been discriminated against or prevented from doing something, hassled, made to feel inferior because of your race, ethnicity, or skin color? And then the second question is very similar, but ask about it specifically while you were getting health care. All right, so here's the rate of moms who never experienced discrimination. We see the highest bar for non-Hispanic white mothers on the left, followed by Hispanic mothers, and then 57.4% of Black mothers said they have never experienced discrimination. If we look at that in the healthcare setting, we see that Black mothers again report much higher percentages of receiving some or getting some kind of racial bias with in their experience. All right, so back in 2021, we did a study looking at discrimination and adverse birth outcomes. So we looked at preterm birth, low birth weight, small for gestational age. And these preliminary findings show that Virginia women who experience racial discrimination as a whole did not experience statistically significant increased odds, but non-Hispanic Black mothers did. And they are the black bar here, and the rate is higher for every single indicator except small for gestational age. So here we see the odds ratios. The only ones that are statistically significant are for our non-Hispanic Black participants. So 2.7 times the odds of having a preterm birth as a result of experiencing discrimination. So researchers have proposed this 12-point plan to reduce Black-white disparities in birth outcomes using a life course approach. I won't read all of them. I'll allow you all to take a look for yourself, but the last 4 points move beyond this biomedical model and address the social and economic inequities that underlie a lot of our health disparities. So closing the education gap, reducing poverty, supporting working mothers, and ultimately undoing racism. So concluding, before we move into our portion about respectful care, we find that adverse birth outcomes like preterm birth and low birth weight, infant mortality are persisting despite genetics, despite any behaviors, despite them receiving the proper amount of prenatal care, and despite their education and income. So potential factors that could just contribute to these disparities are differential exposures to social environmental risk factors, cumulative stress, we talked about like weathering earlier this morning, and then bias. And Black mothers who experience discrimination and bias are found to have higher odds of having adverse birth outcomes such as preterm birth. I'll pass it to Lauren.
Okay, hello everyone. My name's Lauren. And following up on Kenisha's presentation, I think when the first speaker of the day, Dr. Porch, spoke, she really hit a softball up in the air for us in terms of she had a lot of national data and I think set the stage about some things around bias. And then Kenisha was able to give you some Virginia specific data on things related to bias in our systems that are impacting maternal care. And so today I'm going to talk to you a little bit about the respectful care model, which really kind of focuses in some ways on clinical practice, but we will talk a little bit about why it's connected to bias as well. So all of the references will be in my slides and they're hyperlinked if you want to check them out. But I really liked this quote. Multiple studies suggest that implicit bias, defined as the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner, is most likely a contributing factor to this alarming racial health disparity, which I think you've heard this in multiple ways today, but I think it's sort of a nice summary statement. And then the other thing is that implicit bias is a little bit tricky, which Dr. Porch also mentioned this, right? If some of it is about the way you're thinking and the way you're feeling, it's very hard to measure in some ways. You can't kind of climb inside someone's head, fortunately and unfortunately. But some of this is problematic because it is happening in the background and unconsciously. And of course, we all know that you're impacted by your family, your neighborhood, your friends. And so your biases kind of get deep rooted and usually start very early in life. And they can be reinforced by stereotypes you might see. And then the other tricky thing is that our thoughts do and can affect our actions and decisions. And most importantly and key here, our ability to understand others, which I think, especially when you think about the provider and patient relationship, is where this is really problematic. And like I said, but it is really difficult to change our thought patterns and behaviors, and it can take time. And I like to sort of equate this to thinking about, for any of you that have had the luxury, privilege, or challenging experience of going to therapy, You know that even in your personal life, right? If you're trying to change yourself, maybe a coping mechanism or a way you respond to somebody that drives you nuts at work or in your personal life. It takes a lot of time to improve your thought patterns and your behaviors, and then usually what action results. And I put this quote at the bottom of this slide because I thought it was really salient for the day. The failure to recognize the pain of African-American patients, regardless of whether it is conscious or unconscious, has the potential to affect the way obstetrician gynecologists counsel their patients about treatment options when it comes to things like chronic conditions, contraception, vaginal birth after cesarean delivery, which we heard discussed earlier today in patient experience, and the management of something like fibroids. So these are very real things, right? And when you are given different options or a different menu of care, it is certainly going to change the outcomes. And there is ongoing conversation, I think, as well about implicit bias education and how that can factor in to changing kind of provider actions. And earlier we talked a little bit, I think, the term cultural competency came up. And that can be really nice when you are talking about two people that might look like each other, right? And are supporting one another through healthcare or something else. But cultural humility tries to go a touch beyond cultural competency, because I think the idea was thought you can't necessarily be competent in every other culture or groups, practices and ways. So humility is a little bit more defined as a lifelong commitment to being self-evaluative and critiquing yourself in an effort to look at power imbalances that you might be recreating and also advocate for others. And it's important to talk about because thinking about cultural humility is a way that we can all try to mitigate implicit bias. So when you're thinking about moving these definitions to action, cultural humility can help promote empathy, aid healthcare workers in acknowledging and respecting patients' individuality. And it's also suggestive that providers and all of us aim to connect with patients and with one another, instead of just looking at someone and assuming that you know their background or what they're gonna talk like, or just because they speak a certain way, what their education level is, right? So really important to think about. And if you can exercise humility, again, it can be an active practice to help reduce the level the level of impact that your biases might have on encounters with other people. So we're gonna move a little bit into defining respectful maternity care, which again, kind of connects when we're thinking about bias, because it's an active way that there have been some articles written and toolkits created to respond to something like implicit bias that we know is impacting people's experiences of healthcare and their outcomes. So you'll see here, there's some 12 domains. I'm not going to read them all. These are reflected in a few different versions. I'll show you on another slide of kind of respectful maternity care practices. And a lot of these will make sense to you. I don't think there is a lot of surprises, but I think the important part is though they're not surprising and what this includes, they still tend to be very difficult to achieve for a variety of reasons. So again, you know, I wanted to think about not just giving you resources or giving you definitions, but I wanted to show an example of how some of these toolkits are offering how to operationalize something like a respectful maternity care model. So you'll see the category on the right side of the slide, and on the left, you will see some very real examples of respectful care occurring in a healthcare setting during childbirth. And you can see, you know, 2B, unnecessary separation of mother and baby. So really looking for that skin to skin contact. Very common policy practice, and yet we know that some people are not getting that. And there's, you know, I won't go through all of these. And again, you know, I want to emphasize that these aren't really surprising and they're not wild ideas, but I think the issue is that we have to work to standardize, unfortunately, something like respectful care during childbirth. And this is what I was talking about. So you'll see here, there's like a couple articles in the bold across these 3 columns. And they're examples that multiple people have sort of thought of a respectful care model and what the tenets of respectful care looks like. So here are some frameworks that you can see, and we'll talk a little bit more about on the far left, the World Health Organization has also created a toolkit related to this, and I'll show you a few visuals from that as well. So AWON, or the Association of Women's Health Obstetric and Neonatal Nurses, they have a toolkit. So if you're a nurse, if you work with nurses, if you have an interest, checking this out and their toolkit, which I've linked on here, I just wanted to share this visual, but it's really coaching providers, I think, on how we can all participate in doing our work a little bit differently. And I think we also have talked about today, I appreciated Dr. Porch also giving you the categories of like provider, patient, system. You're an individual, but if you're a nurse or a clinical care provider, you're also a provider, and then you work within your healthcare system or setting. And so lifting something like this up to leadership, if you think it would be of value and your facility doesn't do something like this and you need a tool, you know, you can definitely bring this up and say, look, there are resources out there and there's a way we could go about this. I know that not everyone's leadership will respond accordingly, but you know, always trying to be that advocate can be an important step. And they have a wonderful landing page for this framework where one of my colleagues that I worked with a little bit in Atlanta, she's talking on the video, Dr. Rose Horton, and she talks about just how, you know, this can be a fundamental approach to care that's emphasizing rights for women, newborns, and their families. And then really, again, drawing it back to promoting evidence-based care while recognizing unique needs and preferences of people. This is just a couple screenshots from the World Health Organization, or WHO's Respectable Maternity Care Orientation Package. I put a quote in the middle that I thought was nice, but I also liked this: poor quality care is present in all countries. So this refers to another article. And I thought it was nice because it conceptualizes in really approachable language, too little, too late care. So not doing enough or not providing adequate care, but then also too much too soon. So again, we had the example about wanting to have a C-section simply because they're like, the clock's running, you've been here the longest. We'd love to get this over with, you know, despite that is probably unnecessary. So over medicalizing birth. But I thought this was also too little too late and too much too soon, I think, is a nice way to contextualize this information. And again, what respectful care is trying to get at. And this is from their toolkit. I apologize if the slide is blurry. You can find it for free in the link I put in the slide before. But this highlights again those three levels of sort of policy, governments, systems, and individuals and communities. So I'm not going to necessarily read all of this, but it's nice that it categorizes some of the contributors, some of the deterrents, right? So why people aren't necessarily having the outcomes we would like to see and experiencing poor outcomes or treatment, and thinking about how change might occur. And this next visual, I really appreciated. So circling back again to implicit bias being part of everyone's life, but being really challenging. And so I think this is nice. It highlights some of these things around motivation to change, right? Can we provide education? Can we provide knowledge? Talk about empathy. Figure out what your values are and how that affects the care you might be delivering. And then when you have identified what your values are, thinking about then how do your attitudes and your behaviors reflect those, and your performance as a care provider? What does that look like when they are operationalized? And then a couple closing takeaways. You know, I think I just wanted to, one more thing about the WHO, this particular resource. If you're interested, at the end of this document, they even provide an agenda for free that they've already written that gives like an orientation to care managers that explains the concept of respectful maternity care and how to use it. And I think that's really nice, right? So again, if you want to implement this in your own facility or at least have a conversation about it, I think it's nice because it's pretty straightforward and it's a free tool already made for you to like have an event with the content, which can be really nice and take a little bit of the stress off if you're one of the people that's planning it. Okay. So I think realizing that biases will always be present for all of us, I think we can all acknowledge that pretty easily, but then thinking about it, what we actively do to practice reducing its impact. And I think I mentioned this earlier a little bit, but you know, there's been legislation for the state that has come up for implicit bias education being required. And this morning we heard that a lot of healthcare systems might already require that to a degree, which it might be true. And legislation, you know, a lot of advocates have been pushing specifically for maternal health care because of the data you've seen today at both the national and state level would be really important for our maternal and infant outcomes. But I think we have to also consider how we look at something like that over time, right? And I think she gave maybe the police force example and talking about, well, maybe yes, they had a training and they could acknowledge that they had bias, but like over time, right, that might kind of wane away if that's all you do. And the woman, Dr. Rose Horton that I mentioned that worked on the A1 toolkit, she ran one of the maternity units at a hospital there. And what she did with her staff is she actually was having like monthly or reoccurring meetings where they would have like an article or journal club. And so they weren't just doing like case reviews together, right? They were also taking in like literature or stories. And then as a staff, they were like reading them and talking about them. And she was trying to do that exercise repeatedly. And so I think that gives an opportunity to encourage vulnerability, right? It can be scary to really be honest about your biases and how you might not perform your job the way you should be or would love to. And so I thought that was also a really nice example of somebody that was trying to repeatedly bring the information and the education up, but to also support people in their behavior change, which I think is the hardest part. And thinking about the tenets of the respectful maternity care model, they are based on women's desires to be well cared for, but it does feel a little bit like it is largely geared towards clinical care providers, and they are a very incredibly important part of this puzzle. But knowing that it's a little bit about all of us as well, and thinking about advocacy, bringing vulnerability, and sort of modeling what you would like to receive from others, providing feedback when you're a patient, sometimes even when it might not be asked for, can be helpful. Engaging in things like Cinch and 757 breastfeeds, you know, being a part of community coalitions, and really identifying the allies in the work. You know, I kind of made the funny comment earlier that like you could present some of these toolkits to your system administrators or leadership and they might be like, no thanks. But I think if you find, you know, one passionate community member or doctor or nurse, it can be really helpful to identify the champions. There will be someone who is interested in working with you and invested in protecting the people that need to be protected. And so just a reminder that it can feel tough, but I think that there are going to be allies usually in systems. Sometimes it's hard to find them. And the work can be tiring and can be heavy, as we also talked about earlier. And also I wanted to acknowledge, obviously personal safety is an important priority. And so seeking out champions and partnerships is a necessary part of the work. Giving feedback is great, but also taking care of yourself first and your family is really important, but your voice does matter. And this is an incredibly brief list of tools and resources. The things in purple are hyperlinked. You've already heard about the Black Birthing Bill of Rights today, but as a patient or patient advocate, it's a great tool. I think when people understand their rights, it can be really helpful if there is a time that they want to speak up, but it also can support your helpers, like the partners that are present or the doulas. They can also be a part of that equation. That top link is the A1 guidelines that I mentioned, and that would be more for nurses directly. And then this third one, the Institute for Perinatal Quality Improvement. If you are somebody that's looking for an organization that does have some implicit and explicit bias training, it's called Speak Up. for Black mothers, and I've gone through it. It has been a handful of years, so I'm sure it has changed and evolved, which one would hope. But that's a good resource if you are looking for training. Health Connect One is another great organization to check out, and they do wonderful birth worker trainings. They also do participant involved and influenced research in this field that we're talking about, and really work on advocating for birth justice. I was just at a national conference as well, and Mama Certified is a program that hospitals in Cincinnati are doing. And it's really interesting because it is at the city level and has city funds, I believe. But it is essentially a group of Black women and women of color that are working and leveraging, I think it was 4 of their hospitals that I believe had particularly high numbers of Medicaid births and served a lot of Black families that were having babies in their communities. And it was kind of a tiered system, but it was sort of working with them and working with feedback from the community and community-led to really get a hospital to be validated by the community that they're trying to do a better job of serving. So something else to look at, think about. They were really wonderful presenters. And I'm sure if you had interest in talking to them further, they would speak with you. It's not the same at all, but if you've ever worked with baby friendly or like breastfeeding friendly designations, right? I think there's a movement in some areas, some more than others, but to really try to get birthing friendly hospitals, and it's come up with Center for Medicaid at the federal level. But they have very minimal stipulations, I will say. So though they're sort of requiring that, they're kind of like 2 check boxes and might not be quite the same as a community-born, community-led type of effort to really work with hospitals directly. But that was something new that I learned about that I thought was really incredible and impressive. And then, of course, participating in community-based care and building community where you are. I think that it's incredibly easy these days to be isolated. You know what I mean? Even though we have technology, it's not quite the same. And so when you can join coalitions, and you can encourage your friends to use doulas, and to engage with home visiting. I think I loved the PR campaign for home visiting this morning. I told Kenisha that woman was like, we should roll her out nationally. Of course, home visiting can vary depending on where you are in the state, but I think that it does have a real potential to be incredibly positive experience for families, right? And if something's free and accessible and it's a support that you can take or leave in different amounts, encouraging your friends to be open to it and to utilize it can be really helpful. And of course, doulas can also be a great resource of support. And I think I try to do this every day, but keeping in mind that everyone's a part of the change process, right? There are systems and policies. I get the privilege and frustration of analyzing bills that come up in the legislative sessions here in Virginia that impact maternal and infant health. Not everybody listens to my analyses, but doing my part professionally where I can, also showing up to vote so I can individually express where my support lies. And then I think understanding that all these pieces have to move to create and sustain a respectful care model, and that everyone's role might look a little bit different, and that's okay. So sometimes if you can't do it at work, you can do it in your personal life, and that's okay. But still having expectations of those that serve us, I think is very fair. But I think that's it. And here's our contact information. You can email either of us with any questions you might have, but also happy to have any questions now, or if you need any clarification from Kenisha's data presentations, happy to do that. Also, if you don't know, you can do a data request to any VDH data, so birth certificate data like she shared, and then also that CRAM survey.
People in Zoom can ask questions as well.
Is there a way, I can't see the chat in this view.
Yeah, I'm not sure if you can click on it or not, but it's being monitored by somebody else. I think that's just more enthusiastic comments earlier in terms of just happy to be there. But if anybody has questions here or comments or on Zoom, you can take yourself off mute on Zoom as well.
Also, I'd be interested if anybody here does have any, if you are working in like a facility or a hospital, if you do have any quality improvement, quality assurance practices around something related to respectable care ongoing already, and what it might be, if you'd share.
So I no longer work with VCU Health, but when I was with VCU, we had a program, it's called Project Empower, and it wasn't necessarily geared towards pregnant women. However, it was for intimate partner violence and domestic violence. And they have piloted a program since leaving that's geared toward pregnant mothers who have been experiencing domestic violence and intimate partner violence. And so they have been really great in one, making sure that their case managers are women of color. Everyone is doula certified, and so they get the free resource for that program as well. And assist with also postpartum care, therapy, and also just again being a doula throughout the pregnancy. So I think it's an amazing program and wanted to highlight that.
Well, I'll add that we've actually done some work around talking with providers around this kind of thing. And it's one of the reasons that the current work plan that we have for Black Maternal Health Equity Action Alliance is what it is. So outside of this conference, we also have other things that we do, including a whole area of work that we're going to be working with providers around provider accountability, implicit bias, and also what we call equity data and patient accountability and feedback systems. And so I guess it was a couple summers ago, we actually had a sub-project kind of before the new action plan was developed, where we had some summer scholars that we got for free from the university. And we had them call local practices and ask them like what they were doing. Like, do you even look at your own data? Like how we were specifically at that point interested in return for the postpartum visit. And so, and we were interested in, was there a disparity for Black women in particular? But what we learned is that not only did they generally be like, well, we don't really look at that, but we're sure it's fine. But most of them actually wouldn't even talk with us. But they actually, most of them said they didn't even look at their own data. They didn't know how. And so it's part of the reason that we have this, what we call data equity project, sub-project through our provider side of our action teams to really focus on this. And a lot of providers don't want to talk with us about implicit bias either, because we kind of soft floated some stuff and they're just like, well, we don't need that. Like, it's not a problem. And so we're actually kind of approaching it from more of a patient accountability kind of feedback systems kind of loop, and looking at equity data first with them as a way to kind of get them closer and build some trust. But, they don't use community advisory groups in local practices, generally speaking. They don't have good mechanisms. If a patient has a complaint or has a bad experience, they don't really have great mechanisms in most cases to do that. If they do any kind of surveys, what we found is that generally speaking, they're not asking about race and ethnicity at all. So, if you have some patients say, oh, I have a problem at the front desk, right? Because we know that even every single staff person that a Black birthing family interacts with could be a problem, right, in their care system, not just the doctor. It could be the front desk person, it could be the backline billing person, it could be the nurse, it could be, medical assistant, but if you're not looking at that data by race and ethnicity at all, if you're not asking about when you do a survey about race and ethnicity, if 100% of your patients that complain about something or rated low are Black birthing people, you have a problem. But if you don't ask, you don't know. And so part of the work that we're trying to do is that piece. And then some of the other work that we're doing is around the promoting the Earth app, which is actually in your program packet. So we're partnering with the Earth app, which is it's called IRTH. It's Birth Without the B for Bias. It's an app that's basically like Yelp for Black families to find maternal care, so they can provide reviews, both positive and negative, of their experiences to help other families find providers that are good fits. So we're doing that to help increase voice in the community and give patients another opportunity to be able to share information and to have recourse. And the other thing we're doing also in your nice little booklet is the roadmap to safe Black birth, which we have the first 2 chapters out. So it's basically a book for Black birthing families on not just like finding resources, not like, here's the number to your local visiting program, but really more like, how do you have a conversation about implicit bias? What do you do if you feel like that somebody has, in your practice that there's been microaggression? Like, how do you handle that? Like, what do you do? And then also just making them really kind of very well educated on what the risk factors are for them Because we know that, for instance, if you're a Black birthing person and you're starting to have a medical problem, you might not be heard. You might be considered angry, or you might be considered hysterical. And part of the roots of this work originally were because we had another group that was meeting around some home visiting stuff. And a story came up where we had a Black mother go to a local emergency department, pregnant with twins, goes to the local emergency department, says, I'm having a problem. He said, you know, kind of sit your butt down. And they left her there, and she kept going like, something is wrong, something is wrong. And she, as any mother would, started to become louder about it because she knew something was wrong with her body. I think it was like after about 6 hours of waiting in the emergency department, they finally took her up, and it turned out she had fetal demise of both of her twins. And we're not talking, this was not a miscarriage, this was fetal demise. She was like 6, 7 months along. Those babies were viable. And what we don't know is, you know, when she got to the hospital, would it have been different if she had gotten care 6 hours prior? We don't really know that. We don't know that because they didn't listen to her. We don't know that because they actually told her to stop being hysterical. They threatened to call security. Like this was like a conversation we had in the group. And this is where the roots of what is now called the Black Maternal Health Equity Action Alliance, which used to have a little bit of a different name, was born, was because of that voice. You know, and because of the implicit bias that mom, and then after that story was shared, like all these other stories were shared, like a mom whose doctor literally stood with his hand on the doorknob. And this was a mom who had a prior late loss, and she had lots of concerns, and he kept trying to walk out of the room. She's like, I have a question. He kept trying to walk out of the room, and then he told her to, again, calm down, stop worrying her little head, that baby's gonna be fine. This is a woman who has a prior history of late pregnancy loss. You know, so, you know, and again, these are the stories that we're trying to bring out. We also have a project right now, it's called a Voices Project, where we're interviewing moms, and also the survey that is downstairs in the Sitch table is a survey where Black birthing people can give their kind of opinions and feedback if they've had birth within the last 3 years on what their experience has been. And then we're going to use that information to continue to drive all of this work locally.
Curious, when you are doing something like this and you are part of a medical school yourself, sort of what the plan is to process and share back when it's very, I'm sure at times your hospital's also not perfect, right? And you know, how you're handling, I guess, the processing of feedback and sharing it with the community when it does end up being like personal to your own facility.
It's hard. And, you know, some of the, you know, things that we had that happened very early on were with our own facility, you know, and we had to have some very hard conversations with people about those things. The work that we're doing actually is not just for our own practices, it's actually involving practices from across the region. But part of it is, you know, building some trust with those practices to try to get them to engage. You know, our goal here is not to hang them out to dry. Our goal is really to be able to help support their ability to give these patients the best experience and the healthiest outcome possible. And so, you know, part of it is trying to engage them and you know, recognize that, you know, this can be very, very tough work. It's, you know, it's one of the reasons we're doing the Voices Project is because when we have conversations, it's like, oh yeah, well, that happens in Richmond, right? That VCU, or that happened here, or that doesn't happen here. It's not in my practice. And we really wanted to be able to share the stories of local families to be able to help make it more real for them.
Thank you. Any other questions, comments?
If there's anyone.
I have something, excuse me. I'm a clinical nurse manager of a mother baby unit, and I see these things all the time. And I actually had a lot of situations recently with 3 Black mothers in the same situations of things we're describing today. And the way that my nurses reacted, some of them to the situation, really highlighted the fact that they're very unaware of their biases. And it really bothered me that they couldn't understand my line of thinking of how I was trying to support her, and thought I was trying to put them in unsafe situations because someone was raising their voice or they were nervous or scared, and they're trying to make a point like they don't trust us. So trying to build that trust with the mother and keep that with the staff was very difficult. But I had to have some really hard, uncomfortable conversations with them afterwards, and realized that we definitely need a lot more training on this. And that people are not aware of, I see substance abuse or I see prostitution, and that's all I see. but that's not fair to her. She is here to have her child and we are supposed to support her in any way that we can. So getting them past someone's history was very difficult. I literally asked myself, how do I instill this in them? So this has really been great for me to attend today. It's been an honor to receive this information.
And also, I think what really stood out to me this morning as well, and I think it was also Dr. Roche, but she said a loud mama is usually a scared mama. And I thought, healthcare providers of all kinds would do well to remember, just because somebody is eliciting strong emotion, it's not always because they're in danger. It's because they're trying to signal to you, I'm uncomfortable, I'm scared, I'm nervous. Just the opposite. If somebody's totally silent, I would be like, something's going on. But I think that receives a different response, right? And so not responding to anxiety with anxiety. But it's hard to do in practice, even when you kind of logically understand it sometimes. Okay.
Are there any questions from Zoom? Zoom people, you can take yourself off mute and ask a question if you'd like. We can't see your chat, so you do have to take yourself off if you can and say it out loud. See him chat, but.
I'm just amazed with all the good information. I've been sitting here and I really wish I would have came in person because, this really touches the community that I work with. My name is Suzette and I work with at Centurion. We have a baby program, and the things you all are saying are, really touching point to what we deal with. So I just want to say thank you for the invite, and I'm really learning a lot.
Thank you. Thank you for listening and being here.
Hi, my name is Ashley Gregory, and I have a question. Are these respectful mother care models being utilized anywhere locally that you know of in Virginia, in Hampton Roads?
Not that I know of.
Okay, thank you.
Yeah.
My name is Jamie, and I work in Mary Immaculate Hospital in Newport News, and we have a birthplace racial disparities work group that meets monthly, and we have been really looking at our data, not only in Virginia and Hampton Roads, but also at our own facility, especially as it relates to we've been looking at our patient experience and stratifying that by race to look at if there are, discrepancies and differences. And we've also been looking at our severe maternal mortality and morbidity rates and stratifying those by race as well. So we've really been looking into those things, and our little birthplace work group has been actually just recently looking at the A1 respectful maternity care guidelines and how we can best implement that at our hospital. So that is something that we're actually working on. And then we've also developed some resources and references for parents that might need support, especially for various things that are kind of on that list of the social determinants of health, and some of that, access, transportation needs, diapers and car seats, and, just different things like that as well. So we've been doing a little bit of work around that too, but I've been thoroughly enjoying this workshop. Thank you guys all for hosting this important topic and having these discussions. It's a privilege to be here today.
Thank you, Jamie. And I would say, make sure as your facility and your team goes through that, pay attention to how it goes, because I think other facilities would love to understand your process, as you work through it, so that if they're interested in replicating it, they have someone they can go to and ask questions.
Jamie, we would love to connect with you for the provider accountability work teams that we have.
And if there are data points that you're maybe missing, I think Prams could probably speak to that. We can pull it down to county level if we combine years. So if that's helpful, please feel free to reach out.
Yeah, I would love to network or, you know, touch base with anyone who'd be interested as we continue this important work. So I'll put my email address in the chat, and I don't know if you guys are able to see that, but I would love if anyone wants to reach out and connect. I'd love that.
Thank you, Jamie. And I think we're at time. So thank you everybody so much online and in person for being here. It was really nice to have you here and to have this conversation.
And I'll have Mary grab the, on our Zoom slide, she's gonna grab hopefully the email and a chat.
Okay.
Thank you so much. So free to like jump in and everything, and especially someone with good information. Yeah, I know that you started that we are providing like. Yeah, so that's fine. Like, we're trying to figure. Yeah. And then my side, I can work on a phone on letters. You know, anybody can do this, you know, especially when the communities are hopefully supported. You guys, I was about 2 years ago. Yeah. Like if you have like those were we gotta find the money. Actually, a full survey completed for that, like, we're not really starting with small. Actually, I have your, like I said, I think Microsoft Teams, you actually, could you also do, you know, just meetings?
Yes.
You know, yeah, I get those invited as well, but I'm usually like, you know, and so I actually have your, you know, I think part of it is that they actually enrich us in for office.
Yeah.
Okay, so are you like, work from home, or do you actually come in legal and work from home? Okay, yeah, I definitely would. Because I'm kind of working on a project actually because they no longer have like a labor and delivery. Of course, it's just, yeah. So, but yeah, I definitely would, but okay, we all work with EDH, so all I have to do is Microsoft Teams. Oh, yeah. But I'm on the chat, so yeah, I'm HAIM.
Okay.
Yeah.
Well, so what does it want to be like? Hi, if you email you yes,
Yeah, I would love that.
Actually, that's what
back today.
My organization was the bias training, and
well, no, I do too.
Virginia got is what I do, and I appreciate, I didn't hear that, she was like, I know we've during the job, let's see that I can. A little bit,
Yeah.
because most of the, you know, I mean, I've done that with other agencies, and then you kind of get them very. Yeah, I understand that I used to see a
Form, what's specific, like, how usually 2 weeks or less, unless we're busy, right, yes.
Yeah.
So we I can send that to people. So
Yeah, no, I definitely will, because that is, that's exactly, you know.
Yep.
what I did, I, you know, I understand not a particular person, but like, in front of that, you know, Virginia. Just like they know, it's about, you know, it's a function about building over like 25. Yeah. So I also love it here. Well, and it's even like, I mean, I'm very about and have not gotten to be interested in people, both chambers last year.
Friends also.
Pregnancy works. And the way again this year, that's my first. But really wanted. My question is, you know, I've always thought like the climate, like it's really actually on the Midwest, and even more than there's legislation and more is too much.
Yeah.
That's it's been a lot of well, right? But it's still, I would just love to think about like that, you know, we can have a lot of the bias again next year. But it's still. Oh, she and I worked.
Yeah, we sort of follow with the other
decision for that reaction. Yeah. And I'm definitely in I mean, it's part of my year in my like perfect scenario. Like coming down like for me, like everybody.
Literally not a thing.
Like I need a C-section. Right. We'll definitely in here. Before. Yeah. Oh, my name is Bob. Fantastic. Thank you.
Okay, so.
I'm here, I think I'm here till like 5 or so.
That makes a choice.
But you don't know how we they came over. That should be. Yeah, crazy more. So get that straight out of the birth certificate. Yeah. But that would be interesting. I've done some immigration.
That was the one thing that stood out in your presentation. I was like, what?
Yeah.
Why is that? Every time.
But I've seen that with immigration work.
Both
And
my
the
neighbors
numbers
are
are better, the more, and so very simply people immigrated, and then they get worse as you become culturally, yeah.
Oh my goodness.
Yeah, because you're breaking, you're
6'4" now. But, you know,
all and most really die, it's the whole, you know, it's.
great presentation, but you don't consider the move. Is there
And shorter, kind of happy, you know,
5 miles?
Gonna go to 5
Shake her head. Thank you for the great presentation.
Thank you. I thought maybe 5 minutes, isn't that?
Right.
And then like, very low is 2.
Abdominal surgery. My daughter is just turned 20. I am still hot about it.
And I'd like-
Years later.
I didn't even know about it. I know, we're trying to get it on our website and, you know, how they.
A million.
But to make it better.
Million.
I know the big push.
Well,
I'm like, I figured out through it, like I figured it out.
Yeah.
But it was great information. I wish we could pull my son's mistake up here.
We need to find her.
All right, thank you.
Thank you guys so much. It's amazing.
No, we'll probably submit. Do you
Session, so.
Yeah, I said that, a lot of stuff.
Yeah. This room